All right. So again, this is our discussion on the neurobiology of addiction, and the goal of it is to help understand your addicted patient. And it's as all of folks with addictive disorders are complicated. They're very challenging. It's addiction is a discipline, or it's a phenomenon that different disciplines and philosophies throughout our society have given opinions on and have viewpoints on. But we're really fortunate that over the past 30 to 40 years we've made tremendous strides in understanding the neurobiology of addiction. Okay. And let me just stop for a second and make sure that everyone um, can see the screen okay. If you can give me a thumbs up or a chat that you can see it. So right now, what you should be seeing is a full screen presentation. Okay. All right. Thank you so much. Okay. So, see if there's another. Okay, excellent. Thank you. Okay, so going on. Okay, so this is what I'm going to talk about. We're going to go over. Um, we're going to go in this sequence. First, we're going to talk a little bit about addiction definitions, and the phenomenology of addiction. We will talk about some of the non-neurobiological etiologies of addiction. Then we'll talk about the reward network and the neurobiology of addiction itself, and talk a little bit about behavioral correlates, and then we can kind of jump into treatment implications. And I'm going to just stop here for a second because I can't see my notes view. So if there's a way that I can do that and still see my notes view. I guess not. Okay. So, so first of all, we're going to talk a little bit about the diagnostic criteria, and diagnostic criteria from the DSM-5 for addictive disorders. And by the way, in the DSM-5, it's the category is substance use and addictive disorders. And a lot of times I use the nomenclature of addiction rather than substance use disorder, because of course there are other behaviors that are addictive in nature that don't necessarily have to do with substance use, and we'll touch on those a little bit. So I'll use addictive disorder a little bit more in this case. So there are 5 diagnostic criteria in the DSM-5, and they all fall into 4 functional categories. And let's see, let me take a second. I got a chat. And let's see, let me. Jeff is our project manager, and he's kind of my technical support. So I promoted him to a panelist, so he can help me if I need some help. All right, so so the 4 functional categories, and these are really diagnostic clusters, and there are other diagnostic criteria of those 11 that fit in to these categories. So the first one is impaired control. Then we have social impairment, risky use, and tolerance and withdrawal. So first, impaired control. This is when basically when you have a person who loses control over their behavior, and this is in general kind of one of the beginning stages of addiction where you begin to have loss of control, and and some of the criteria for this particular diagnostic cluster people are familiar with from the cage questionnaire. So uh, attempts to cut down and inability, that's one of the, and then continued use um, for the cage. And so impaired control, what that looks like is, again, you'll have a diminished ability to stop. Folks will use for longer periods of time or in larger amounts than were intended. Um, Folks will want to cut down and be unable to. They'll spend excessive time and effort in trying to get more of the addicting substance. And also, and this is new in DSM-5 as compared to DSM-4 criteria, and that is the addition of intense cravings, and that's an important part of addictions. So there's this craving that underlies the compulsive need to use. Um, Social impairment, that's the other diagnostic cluster, and actually, uh, so this is the case where people might continue to use despite problems that it's causing them in work, school, other social obligations. And the criteria that I have underneath that, the 1, 2, and 3, those are actually DSM-5 criteria that fall into that category. So again, it's basically problems with work/school, problems with relationships, and then problems with other social activities. Uh, Risky or hazardous use. This is um, in the case where a person with the addiction will continue to use despite the knowledge of the harm that it causes. And this can come in the form of physical harm, psychological harm, or other social harm. Um, so um, it can be people using substances in an unsafe environment. And kind of the classic case of that is in a car while driving. That's would, if someone's got a DUI, that would definitely meet this particular criteria of risky use. Um, Using it in situations in which, you may put yourself in at risk of harm. And this unfortunately happens sometimes with, um, um, young teenagers, and sometimes they'll put themselves in risky situations, and will get exploited. Engaging in criminal activity in exchange for substances, and then again continuing to use despite having major health problems. And you can kind of picture these folks, someone who may have end stage liver disease and continue to drink, or in the case of nicotine dependence, someone who has had a laryngectomy and continues to smoke. And there's lots of other examples. People have had an overdose, but continued to use opioids. And then the fourth diagnostic cluster are kind of the physical manifestations, and those are the tolerance and withdrawal. Tolerance is basically um, requiring more of a substance to get the same effect as in the beginning. There's saying, and it's your first high is always your best. It never gets better than your first high, because and that's really true from both a phenomenologic standpoint and a neurobehavioral standpoint, and we'll see that a little bit later on in the presentation. And then withdrawal, of course, and I think everyone is familiar with what that looks like. So just kind of to summarize some of the phenomenology that we see with folks with addictive disorders. You have an inability to abstain. You have a an impairment in behavioral control. So you have this compulsive use. It's always characterized by some type of craving. There's really a diminished recognition of the problems that are arising from the compulsive use of the substance or behavior. And so, you know, denial falls into this category. Um, it, you know, addictive disorders are generally chronic and relapsing, and that's just kind of part of the condition. And that without treatment, the condition generally progresses and can end up in disability and or premature death. So the etiology, as I mentioned, before I get into the neurobiology, I'm going to talk a little bit more about some of the other etiologies of addiction. And etiology follows a classic biopsychosocial paradigm. And this is the case for a lot of our mental health conditions, and even the case for a lot of our major health disorders that have a behavioral component, such as diabetes and high blood pressure and obesity, just to name a few. So a little bit about heredity. Most studies have, and this is over the course of probably the last 3 to 4 decades, they've done a lot of twin studies, both on dizygotic and monozygotic twins, and family linkage studies. And basically what they've shown is that there's a high degree of heredity. The genetic component is about 50%. Now with this is that 50 to 60%, that is true based on the data, recent or meta-analysis done about 6 or 7 years, basically verified that, looking through all of the studies to date. However, recent information regarding epigenetic etiologies um, really decreases that a little bit, because those are, more in the environmental category of etiology. So, I think in the next few years, I think the cited statistics for genetic contribution will be more like 40% and 40% genetics and 60% environmental. So children of persons with addictive disorders are 8 times more likely to develop an addiction. So just kind of that sort of tells the story on the genetics. Of course, with any behavior, there's going to be environmental modeling, which is an important part of initiation and maintenance of a behavior. So, people of all ages are vulnerable to peer pressure. This is particularly the case in adolescence, and unfortunately, adolescence is when folks are beginning to lay down some of their behavioral patterns, for their for their adult life, and a lot of folks begin their serious substance use in the adolescent years. Um, and then, of course, use in the family system propagates, not only from a genetic standpoint, but also from a social modeling standpoint, propagates the development and maintenance of addictive disorders. So trauma, there's a lot to say about trauma, and I'm just going to basically kind of just barely touch the surface. Um, this is could be a 2 hour talk, and then only get the part of it. But it's been shown that about 50% of people who survive abuse, or and that's just and this can be kind of one form of abuse or some sort of trauma, develop a substance abuse issue. And then um, even as after a one-time event, the rate of people developing a substance use disorder has been shown to be 1 in 10 to 1 in 3. So with the um, uses of addictive substances, very, very common with trauma, and with traumatic events. This is a slide developed from the adverse childhood experiences studies and data sets. And adverse childhood experiences are there's basically 10 of them that are classically cited as particular experiences that are cited in childhood as being traumatic, and basically they fall into the category of the traditional types of abuse, so physical, emotional, sexual abuse, um, neglect and or disrupted attachments, and then witness to violence. They mostly fall into those categories. And the again the ACE questionnaire has 10 items on it. And so as you can see with this chart, for people that have had 4 or more adverse childhood experiences, let me move my toolbar out. The odds ratio of developing either an alcohol use disorder or an IV drug use disorder are over 10. So people that have 4 or more adverse childhood experiences, their likelihood of developing an addictive disorder is 10 times, at least 10 times that of the general population, which is really, really remarkable when, from a statistical standpoint. So a little bit more in terms of etiologies, um, as as is commonly cited, co-occurring psychiatric conditions are more the rule than the exception in folks that have substance use disorders. And part of the causality of substance use disorders is the fact that folks are self-medicating. And I see this a lot in adolescent patients. I'm the medical director for Desert Sage Youth Wellness Center, which is a inpatient residential facility for Indian youth in Southern California with addictive disorders. And I do all the psychiatric evaluations on them. And very, very commonly, I'd say, and this is anecdotal, of course, but I would say 2/3 to 3/4 of the time, the adolescents will very clearly link their distress, their symptoms, a lot of times their anxiety or depression, with the initiation of their substance use disorder. So self-medication is a huge factor in the development and the etiology of substance use disorders. So just some of the statistics that go along with that. Um, the vast majority of people with a substance use disorder also have a psychiatric disorder. I think these figures are actually a little bit on the low side. I think these come from the National Household Drug Survey, which is done by the federal government. Um, about 50% of all folks with schizophrenic patients have a substance use disorder, according to the literature. I would argue that it's probably higher than that, at least in my experience. Um, the risk of co-occurrence of substance use disorders with any affective disorder, so major depression, dysthymia, bipolar disorder, the odds ratio is 2.3. Oh, I'm sorry. So that's any affective disorder, it's 2.3, and then for major depressive disorder, 2.7 and 9.2 for folks with bipolar disorder. So, so in a sense, the more severe the impairment with the affective disorder and the more distressing the symptoms, the higher the risk of substance use disorder. And when you think about it, from a logical standpoint, that certainly makes sense. In terms of folks with anxiety disorders, folks may have heard that anxiety disorders are the most common psychiatric conditions, and um, and at least a third of folks with anxiety disorders also have a co-occurring substance use disorder. Now, one thing that I didn't mention on this co-occurring disorder slide is folks that have been traumatized. We found that in residential populations in adolescents, over 90% of the residents, the adolescent residents in treatment, have some significant history of trauma, which is causing them some clinical stress. So we're going to shift a little bit, and we're going to talk about the reward and motivation neural network. This is the particular neural network in the brain, which really accounts for the majority of addictive behavior. And most of the research that's been done over the past 40 years has been focused on the dopamine network. The dopamine hypothesis of addictive behaviors first came out in the late 80s, and and of course there's been more developed since then, but it's been around for a while. There's actually three separate networks that have been found to be involved in addictive behavior. The literature refers to them as the like system, the want system, and the learning system. And I like to think of it as the Cold Stone triad. Like it, love it, gotta have it. If you've never been to Cold Stone, that's their sizes of their ice cream. And that's a little bit of one of my addictions is ice cream. So the motivation and reward system in the brain serves a purpose. It first of all, it's very highly preserved in across vertebrate species, and it confers advantages for evolutionary survival. So it's very important in mating. So sex, preference for calorically dense foods, so eating behavior, and and this has been shown a little bit more recently, avoidance of pain. So in the case of sex, they found that there's a dopamine spike of about 200% above baseline um, after sex. Um, you get a little bit less of a dopamine spike from your favorite food. So that Cold Stone ice cream that I'm thinking about now, that increases the dopamine release about 150 times above baseline. Um, the avoidance of pain, as I mentioned, that has been that's a fairly recent discovery. They did a really interesting study several years ago where they had rats and they shaved the hair off and then they put on their skin, which is capsaicin is that's in hot sauce, and it's a hot, uncomfortable material when in contact with the skin. So put this capsaicin topical ointment on skin of a rat, um, and then waited a certain period of time, and then um, put a topical anesthetic on. So not an opioid at all. I think it was lidocaine or some other type of topical anesthetic. And so first of all, let me back up with a capsaicin. The rats demonstrated some of the classic pain behaviors. So grimacing, increased motor activity, increased vocalizations that displayed distress, and so that's how they kind of measured the pain response. So after they applied the topical anesthetic, um, they hooked them up to a sensor and detected dopamine release upon the relief of pain. So just the very act of relieving pain or discomfort in a human being or in any vertebrate um, gives a dopamine release, which kind of makes sense from an evolutionary perspective. You want your species to avoid things that are going to be damaging to them. So to further reinforce behaviors that avoid that, that the there's a reward that comes from activities that are soothing. Now that has implications in terms of treating pain patients with opioids, not only and I'm talking about pain primarily, and it could be physical pain, but maybe to some extent psychic pain, although this part hasn't been researched. So not only in pain patients do you have the endogenous effect of the opioid or the receptor effect of the opioid causing a dopamine release, but you also have the relief of pain, which also causes a further dopamine release and reinforces that behavior. All right, so that's the evolutionary advantage of the reward system. So back to the three parts of the reward system. So the first part is the registration of sensory stimuli. So this is where the organism basically just receive the signal in the brain of the pleasurable stimulus, and the places where that signal is received is in what we call hedonic hotspots. These are distributed in various areas the in the midbrain. There's some hedonic hotspots also in the cortex, and this is just a little graphic. This is actually a rat brain, but if you can extrapolate this into a human, it's in kind of similar areas. So far, they've found hedonic hotspots that involve dopamine, opioids, and anandamides, those particular receptors. Um, Anandamide, which is actually where cannabis binds, and anandamide is your body's own endogenous ligand for that receptor, and then orexin. And so orexin, as some of you guys know, is associated with hunger and feeding behavior. So it kind of makes sense that there would be an orexin hedonic hotspot in the brain. And it has been, in fact, shown to be correlated with eating and feeding behavior. So that's the first part of the system, the like it. The second part of the system is that part that we know a little bit more about. We've, as I mentioned, the dopamine hypothesis of addiction, came out 30 years ago now, at least. Um, this is basically in this part of the system, the original signal that's received by the hedonic hotspots is then transmitted to the ventral tegmental area and the nucleus accumbens, and this is where the dopamine is released. The particular um, portion of the addictive behavior that occurs here is basically the valuation of that stimulus as pleasant. So, in the hedonic hot spots kind of say, oh wow, that's something, and then that signal is transmitted to your nucleus accumbens, which basically says, oh yeah, that is really really good. So that's your love it, where you have amplification of that pleasurable stimulus, and kind of that's sort of where the organism is being told just how good that uh, particular stimulus is, and and again, this is at the level of the dopamine receptor, and we'll talk a little bit about the two different types of dopamine receptors in the brain, and why that's important. So the third part of the reward circuit is we call it the gotta have it circuit. This is the learning part of the circuit. Basically, this is where relative salience of the stimuli is performed in the brain. So so not only do you have the registration of the pleasurable stimulus in the hedonic hotspots, the kind of the amplification um, and intensity. You get some sense of the intensity through the dopamine system, and now in the cortical areas is where you kind of rank the stimuli. So unfortunately, in the case of addictive disorders, the stimulants, the addictive substance in this case gets prioritized very very high in the mind of the individual who's addicted, and that's that kind of causes some of the problems later on. This is also where some of the association cues are formed. So, for example, um, people, places, and things that make it difficult for folks in recovery. Um, you make the associations with the between the substance and a place or person. And another example of this is when people are trying to quit smoking, you want them to take out all of the ashtrays in their house. You want them to create some sort of an alternate routine um, to do when they are after they do some activity that's associated with smoking. So some people, they'll when they're on the phone, they'll have a cigarette. So instead of lighting up, you'll have them chew some gum or something. So you have this behavioral substitute, and basically that's the unlearning of those cortically associated behavioral cues. Okay, so that's the gotta have it. This is a chart of the various drugs of abuse. This is not all of them. And the way I've organized it is you can see on the left-hand side, roughly from an excitatory neuronal state down to an inhibitory neuronal state. Um, and that also correlates, but it has behavioral correlates between stimulation and sedation or depression, and that's why you got the stimulants up towards the top and the depressants down below. So I won't go over everything on the chart, but I've also got, so I've got the receptor uh, that in the brain where the addictive substance binds. So you have the NDMA, glutamate related receptors, dopamine, serotonin, cannabinoids, mu, and GABA. And then I've got the drug class and the examples of that. So ketamine is a very powerful dissociative. They are beginning to actually they've been using it for the past several years to treat depression because it from a therapeutic standpoint it dissociates the cognitions from the emotions and will give people sometimes very immediate relief, particularly a very troubling thought such as suicidal ideation. Um, and then I've got the effects on the right hand corner. I'm not going to go over them again, all of them, but you see dopamine there. That's very central to the addictive circuitry. Um, Meth and regular amphetamine, they cause a release of dopamine about 1,000 times above baseline. So it's the most potent stimulator of dopamine release, and part of that is due to the receptor. It methamphetamine actually works on the dopamine receptor um, and causes direct release of it. Cocaine is a little weaker of a dopamine stimulator because it actually works on a receptor which is related to dopamine, but it's a reuptake blocker basically. So it kind of increases dopamine in a more passive manner. Mu opioid, as you can see, of course, we're concerned about opioids, and that um, it only the dopamine release associated with that is only about 200% above baseline, which on kind of from one standpoint is kind of surprising based on the fact that it's so very hard to be in recovery from. It may be, and this is just my own postulation, it may be that other mechanism about relieving pain um, in and of itself causing an additional release of dopamine, which wouldn't necessarily be detected in these receptor drug studies. That may be adding to the addictive nature. And then, of course, the fact that withdrawal syndrome from opioids is so unpleasant. That's another, I think, very strong contributor to the fact that opioids are so incredibly addictive. And then you see GABA down below, and alcohol and benzodiazepines on that. Okay, so I'm going to talk a little bit about some of the behavioral correlates of addiction. It's really kind of a system, a reward and motivation system that's been hijacked by by substances of abuse, and basically what you'll see is restriction of volition, where the motivation and reward circuitry is not working the way it's supposed to. So and we'll talk a little bit more about that and when we talk about the particular neurobiological disruptions. I've got a couple of slides that describes actually all of these. So restriction of volition, restriction of those non-addiction related activities that kind of sustain us. Um, looking at the sunset or petting our cat. The things that we kind of find meaningful in life. And enjoy. Restriction of decision making and restriction of affect. So we'll see these things clinically. So this slide has got a lot of stuff on it. There's actually two primary um, disruptions that are occurring, and let me go over them separately. So the first one that I want to go over is the one on the top. I don't know if you can see my cursor, but basically stimulation of the dopamine receptor causes an increase in the stress response mediated through corticotropin releasing hormone. Um, and those neuronal projections are into the amygdala. So you're basically you're when you have more dopamine, you're actually making your stress resilience less. So you're making it harder for people to deal with stress over time. And this is always something that I tell my folks, particularly that are on benzodiazepines. That's one of the very negative aspects of using any type of potentially addictive medication, is that it can actually, if you're using particularly one that's being used for anxiety, um, while you're using it for short-term relief of symptoms, it's in the long run making it harder by decreasing your stress resilience, increasing your stress response, and then also and that's mediated through corticotropin releasing hormone and dynorphin, which is another um, agent in the brain. So that's one mechanism that worsens your anxiety and your affect. The other one is well, I'll just go through it on the left. So you've got you've got two different dopamine receptors, as I mentioned before. You've got the high intensity reward receptors. Those are ligand gated, so they're very fast acting. And those are, your sex, drugs, rock and roll receptors. So they register high intensity rewards. You also have another dopamine receptor system that registers low intensity rewards. This is a second messenger system, so it works on the genome, and it's a lot slower acting. And one of the nasty things that occurs when people are addicted to substances is that when they stimulate the high intensity reward, it basically through feedback loops shuts down the low intensity reward system. So people literally, oh, I'm sorry, go back. People literally lose their ability to enjoy normal things or things that they used to enjoy. So, clinically, we'll see an individual who, say, used to love golf, and they'll begin drinking a little bit more, and then drinking is really the only thing that interests them, and they'll stop golfing. Pick your hobby or pastime. Um, and they lose the ability to do that, to get any enjoyment um, out of those activities. Another disruption from a neurophysiologic standpoint that occurs is a hedonic tone reset. So the hedonic tone is basically kind of your baseline ability to be content and or enjoy what's going on around you. So kind of when you're at rest. What they found is that folks with addictive disorders, their hedonic tone is actually a little lower. So they have a little bit more difficult time just enjoying normal things to begin with. So they're kind of a little starting a little behind the eight ball. Unfortunately, if they start using an addictive substance, what happens is they get, this temporary increase in their hedonic tone. They feel good, they get the euphoria, um, but over time, through neuroadaptation, um, that hedonic tone decreases, their hedonic center, their set point decreases over time. So what you see is that as people progress in their addictive disorder, it's number one, they develop tolerance, and each attempt at getting euphoria out of it becomes increasingly futile. And then a lot of times I'll see folks who have, been using substances for a long time, I see that's a lot with methamphetamine and opioid use disorder, where people are using, they are not enjoying it at all anymore. They are just trying to fend off the misery, and that's all. Um, and a lot of times, if if folks have the insight to see that, then a lot of times that will be one of the intrinsic motivators to get them to seek help because they realize the futility of it, the fact that they are miserable all the time and they need to do something different. So just to kind of review, you get from those neurobiological systems, you get the um, restriction of volition, which is motivation. So your motivation circuit doesn't work anymore. You lose the ability to enjoy normal things. So your range of activity really becomes very limited and kind of tightly encircled around an addictive behavior. Um, you get restriction of decision making because part of the cortical part of the reward and motivation system is to help you to prioritize things in your life. When it's being disrupted um, by a highly stimulated dopamine circuit, then you really lose the ability to kind of make fine judgments between things and to prioritize. So that it really affects the executive functioning part of the brain. And then of course restriction of affect, and that's kind of with that hedonic set point. And there's we see this happen all the time, particularly as people get further in, kind of and progressed in their addictive disorder. It might be interesting and fun in the beginning, but it really, this is through these mechanisms, this is really how it wreaks havoc on a person's life. Okay, and those are my references. So at this point, I am um, going to stop sharing and just kind of talk to you. Um, so I wanted to check to see if there's any questions or, you know, I, I've probably, I've got hundreds of examples of that illustrate each of these points, and I'm sure you guys, if you think reflect on some of the patients that you see, or even people that you've seen these processes occur to them. So any questions related to this or related to anything else? Yes. Okay. So there's a question regarding, is there a scale of dopamine releases that we can refer to? Yeah, actually, if you go to, I think it's NIDA's website, National Institute of Drug Abuse, um, and you navigate to their neurobiology section, they've got some of those slides on there. Um, One of the things I forgot to mention, which I actually ran into this morning, as I was just kind of reviewing my slides and reviewing some of the latest research, video games falls between food and sex in terms of um, dopamine release. So, there's been a lot of talk about video game addiction, and there's hard neurophysiologic correlates to why it's so addictive. It's maybe not quite as good as you know um, as good sex, but it's better than your best ice cream at Cold Stone. Um, so Jeff has got a question regarding hedonic tone baseline reset. Yes, the good news is that when folks stop using, the hedonic set point um, eventually returns to baseline. Now, if someone started with a baseline that was a little lower, it might not go quite up to normal, but it'll be normal for them. What we like to see is that folks that are in recovery actually begin to learn more tools and learn to do more activities, so they might actually be able to bring their hedonic set point up a little bit compared to what it was before their addiction. um, so I've never seen any research saying that it goes to normal or above normal, but we see that clinically, that people through good recovery treatment can gain coping mechanisms that really make them better than they ever were in the past. Now I have the one possible exception to this, and this is anecdotal, so I there may be a study on this that I'm not aware of, but a lot of times if you have a patient that has used methamphetamine for a very long period of time, at least clinically, I've seen that they have a hard time um, enjoying kind of the little things again. um, Particularly someone who's used it for 20, 30, you know 40 years heavily. A lot of times I think the theory is that they just kind of burn out their dopamine receptors, and I don't know whether that is true from a neurophysiologic standpoint, but it sure seems like it um, clinically. Any other well, let me just, I'll talk a little bit about Telewell. And so This is part of our webinar series for Telewell. Telewell, we are state funded and SAMHSA funded um, MAT project. Our goal is to expand medication assisted treatment services throughout Indian country in California. And so we're working, we're trying to connect with tribal and urban Indian health programs throughout California. We've got some very good partners, Sakui, California Consortium of Urban Indian Health, CRIB, the California Rural Indian Health Board. We've got folks. We're working with folks at USC and UCLA, and that's just to name a few. So there's a big push right now to really expand um, life-saving medication-assisted treatment out into Indian country, because it's been so devastating in Indian communities. We've mentioned this in previous forums, but the rate of opioid overdose in California is 3.5 times in the native population, 3.5 times more than the general population, which is very, very disturbing, and something that needs to be addressed and is being addressed. One of the things that we can provide is technical support to people and programs that want to develop their own MAT program. We can also provide tele MAT. So for programs that may be not quite ready to jump in with both feet and maybe want to see how it's done, we can provide tele MAT at no cost. It's funded through SAMHSA, and you can contact us by going to our website. That's www.telewell.org. Okay, any other, let me see. Okay, all right. Well, I don't see any other questions, and we are 1 minute of 1 o'clock. So I am going to go ahead and wrap it up.